I have the pleasure as a clinician to introduce you to the concept of hepatitis C drug resistance, which would really belong into the hands of a virologist. But in order to make it understandable, I think we chose a clinician to move this forward. So the first thing you have to understand are the mechanisms of resistance. And Jean-Michel Pawlowski, who is a famous French virologist, has very nicely put a concept forward. So one thing you have to remember is that hepatitis C replication occurs at a very high rate, right? So there's a very high replication, and unfortunately, there's prone in this high replication process that there are mistakes, and so the probability of polymorphisms which confer resistance is actually very high. So in a given patient, you will find a dominant wild-type population which will be sensitive, but there may be polymorphisms present which could potentially confer resistance. Under the then following administration of a drug, you create selective pressure under the drug exposure and then can create resistance in the setting of virological failure, which leads to an increase in the frequency of the resistant virus and to obviously a decrease in the wild-type population, which was present at baseline as the dominant viral species. If you then stop the drug, you can imagine two scenarios. The one is that the wild-type reemerges because of the viral fitness, which is impaired in the setting of specific mutations, and that is actually something you will see in the presence of hepatitis C protease inhibitor-related mutations. So the virus does not feel very well and does not replicate well with PI mutations, and so over time, the PI mutations disappear and then can be found at lower frequencies and wild-type reemerges. Or you can have the emergence of viral variants which confer resistance but to have no impact on the viral fitness and remain the dominant viral species. And that would be the case in the presence of NS5A mutations, which you commonly see and which so elegantly have been described by Professor Ahn in the setting, for example, of zanepravir decladisvir failures, where indeed the 31 and the 93 mutations usually persist after failure. So what are general aspects of DA resistance? So obviously, what you heard in this very elegant talk before me was that we have a whole range of different antiretrovirals which can be classified into various groups depending on the target within the replication cycle. And these different drug classes differ substantially from each other with regard to resistance profile, pangenotypic efficacy, and other characteristics. Now, you have to separate between what we would call protease inhibitors of the first generation, which would be boceprevir, telaprevir, cimeprevir, and protease inhibitors of the second generation. And remember that Jean-Michel has brought forward a definition. What is a real second generation drug? It's a drug which is active and works in the presence of mutations from a first generation drug. So remember that he introduced the term of second wave DAA. That means that you sort of have maybe a newer compound, which is maybe easier to give or has a difference in its tolerability profile, but doesn't really change very much with regard to activity, with regard to mutations which confer resistance to that particular compound. So a true second-generation drug is something which works in the presence of mutations achieved by a first-generation compound, and a very good example for that would be in the HIV field, that if you have an indinavir mutation, you would still be susceptible for darunavir, for example. That would be a true second-generation protease inhibitor. So obviously, there are huge differences. And you can see that with regard to resistance profile, only the nuke polymerase inhibitor, which would be predominantly sofosbuvir, is marked green. So that is the compound or the drug class which has been associated the least with resistance emergence. And may also be a reason why in many sofosbuvir-containing regimens, the impact of resistance may be somewhat different than in some of the other combinations. Obviously, you can see that protease inhibitors of the first generation and also non-nuke polymerase inhibitors are associated with a very low genetic barrier and high emergence of resistance, and obviously that may play a role in the subsequent utility of these agents. Now, there have been, just like in HIV, and many of you will be familiar with that, there has been a classification and description of the signature mutations, and you can see that for the various compounds. Note that if the oval, so you see black ovals which are filled or not filled, if they are filled, then in patients who experience virological failure, more than 10% of the virologically failing patients depict that particular mutation or amino acid substitution, whereas those which you see which are not filled are really rare polymorphisms which may occur in variants. And if you look at it, it's maybe a little difficult to read, but it's important to appreciate that depending on your genotype and your subtype, different amino acid substitutions may occur, which then eventually confer resistance. So it's different for every genotype and also for every subtype. Now for telaprevir example, the main mutation is the R155, and it's a difference whether you have the 1A or with the 1B. In the 1B you see more prominently the 168 mutation. So it depends a little bit on which subtype you have, which mutations you see. And so what you also will appreciate though is that, for example, the R155 is a common mutation which is seen throughout many different available protease inhibitors. So also suggesting that there's considerable cross-resistance, just as you know from the HIV field where we had pretty much the similar phenomena with the first generation protease inhibitors. And then seeing that the Q80K is this particular mutation which is found most frequently in cimeprevir failure, so it plays a special role for cimeprevir, which is not necessarily the same for other protease inhibitors. Looking at NS5A inhibitors, and you already have heard the significant impact these NS5A inhibitors have in the connection with the zanepravir, decladisvir treated patient population in genotype 1B. And you can see here that with decladisvir you can develop a whole range of mutations, and the most dominant ones are really the 30, the 31, and the 93. And you see these are all bold, which may be and actually can be found for genotype 1A and for 1B. And you can see also the Q30 and the Y93 mutation for ladipasvir and obitasvir. So there's considerable cross-resistance between the NS5A inhibitors, and it's fair to say that these are the signature mutations. Looking at the non-nuc inhibitor resistance, and you know that the biclabavir is a drug which is now developed as the BMS3D regimen, is not available yet. But you can see from dasabavir that there also are significant mutations, in particular the S55-6. And then for sofosbuvir, you can see that very few patients, because this is all not filled out in bold, have developed resistance in trials. There are very few patients who, when sofosbuvir was licensed also for use in patients on the transplant list, so over extended periods, long treatment periods, much longer than the usual duration, developed some mutations, particularly the L159 mutation. There have been some patients upon retreatment who ended up with an S282 mutation, which is at least in various experiments associated with a loss of susceptibility to sofosbuvir, but it's fair to say that in thousands of treated patients, this mutation has hardly ever been found. Now, this is looking at the prevalence of baseline genotype 1 NS5A RAFs from studies with the ABI3D regimen. And I just chose that arbitrarily. It could have been any other regimen. I think the important thing is if you start talking about resistance, you have to understand that companies have been using different assays to determine resistance and different cutoffs. And that's very important because there's obviously also commercial interest in the way they show their data, right? So if you do ultra-deep sequencing, and most people who do HIV think that ultra-deep sequencing is important because it picks up low frequencies of mutations which eventually may have an impact. And actually, Ventura, who's sitting in the first row, has someone in his lab who did a lot of work around that, Roger Perez, and showed that the K103N, if it's available in deep sequences, actually has an impact on subsequent treatment success. However, here it's a little different. So remember, high replication rate, very prone for the development of resistance. So if you have a very low threshold, you're going to pick up everybody who has a mutation, which is very likely because of that high replication process. And if you take the 1% detection threshold, you can see that patients who have mutations or substitutions in the NS5A class is actually much higher than if you use a population-based sequencing, where the cutoff usually is around 15%. So depending on which threshold you use, you can find a higher frequency of RAFs. Now, if there is an impact, obviously, the more you dilute your sample, the less likely it will be to have an impact. So you eventually, if you always use the 1%, you're going to miss whether there's a real impact or not. So there's a little bit of word of caution here, because some companies have only done the 1%, and then there are companies like Merck, which did the 15% first, saw an association, and then went on to do the 1%, lost the association, and now are struggling between the different cutoffs. Now, in the particular situation of the AVI3D drug regimen, and you can see here that there's another important point to make, is that actually you do not only look at NS5A RAFs as a total, but you will also have to look at which of these NS5A polymorphisms are actually associated with a reduced susceptibility to the drug you're using. So the next thing you're going to look at is what is the amount of RAFs which are specifically associated with an impact on bitosphere. That is the NS5A inhibitor in the AVI3D regimen, and you can see that then depending on your threshold, you have 19% or 11%. So what you would expect is that if there is going to be any kind of impact, it only can be those who have 15% detection threshold, so a high enough percentage of that bitosphere conferring resistance which may have an impact. However, remember that the AVI3D regimen comes with ribavirin, and that can overcome some of those resistance issues. So in that study, there was no impact of RAFs altogether, but it's at least important to understand that when you look at resistance, you have to look at what is the cutoff. Is it 1%, 15%? And are you looking at RAFs altogether, or are you looking at the specific ones which reduce the susceptibility to the agent which is in your combination? Now, I already alluded to that the presence of resistance after stopping therapy is dependent on the viral fitness. So in the setting of hepatitis C protease inhibitor therapy, and this is taken from patients who received telaprevir, PEC, and interferon, in those who develop virological failures, you can see that many months after treatment, and this follow-up goes up to 18 months after treatment, most of the patients tend to lose their mutations. And there's a difference whether you have the V36M alone, or the R155K alone, or the combination of the two, and you can see so that depending on which mutation you have, you can lose that faster. If you have combinations of mutations, you actually lose less fast. What I've not showed here is that there's also the same kind of graph for genotype 1b, which actually is different. So your risk of resistance with 1b is lower, and your time to losing the mutation is actually faster. So there is, again, a difference in the mutations which are occurring and the speed, how they are being lost over time in the setting of the genotype 1b infection. This is a paper which looked at the long-term persistence of NS5A variants. So in contrast to the hepatitis C PI mutations, these were patients who received ledipasvir in the absence of sofosbuvir, and they looked at the positions which conferred at least a 2.5-fold reduced susceptibility to ledipasvir. And what they saw is that at virological failure, everyone except one patient had developed NS5A mutation. So that's one of the other things in clinic. If you fail on an NS5A inhibitor-based regimen, you're very likely, depending on the duration of therapy, to develop these amino acid substitutions. And you can see that after 2 years of follow-up, the majority of patients still depicts that particular mutation or those mutation sets. So that tells you that NS5A mutations are actually quite troublesome, because if they appear, they persist. And as that will have an impact on future therapies. And as such, you would expect that resistance testing after failure to an NS5A inhibitor-based regimen would make sense, because then you can sort of think about whether there is an option to circumvent or to deal with the particular resistant mutations you may find. This is another nice study looking at the persistence of RAFs in patients who relapse after 3D regimen. And since the 3D regimen is composed of a protease inhibitor, an NS5A inhibitor, and an NS5B inhibitor, you can nicely see after a year of treatment what persists. So you can easily see that the PI mutations to paritaprevir, after 48 weeks, there's only 9% left to have a conferring mutation, resistance conferring mutation, whereas there's no change in the beta-sphere mutations, and there is something in between change for the NS5B inhibitor. So it really tells you that NS5A inhibitor-related mutations are the one to think about and to worry about, because those are the ones which remain at a high frequency and persist after virological failure. Now, what do the guidelines say? The guidelines are very clear. They say hepatitis C resistance testing should not be performed prior to therapy because the SVR rates are very high, both in patients with and without detectable amounts of resistance-associated variants, by means of population sequencing. So here you see there's a suggestion to use the 15% cutoff rather than the 1%. And the only exception they have at that time, and remember though that the EASL guidelines were issued prior to the release of the grazeproof-elbasvir combination. So here this is only for PEC, riba, and cimeprevir, and we'll come to that in a moment. The utility of hepatitis C resistance testing prior to retreatment who failed on any DAA-containing regimen is unknown, so there's no firm confirmation. I think we're going to see how that changes, and I'll try to walk you through some of the data which explains why it may make sense to do a resistance test or not. Now, what does the label say? And I have to say that I left out the cimeprevir decladisvir combination, and I'm very grateful to my colleague, Professor An, who has already covered that so nicely, because obviously there is also a strong impact of the NS5A mutations. For the two other compounds which are more broadly available, when you consider cimeprevir combination therapy, it says if you use that with PEC and riba, you should be tested for the presence of the NS3 Q80K polymorphism, and the Sepatier label, which is the grazeproof-elbasvir combination, requires for genotype 1A testing for the presence of virus with NS5A resistance-associated polymorphisms. Note that this is in the FDA label. This is not in the label in Canada, and it's also not in the label, presumably, for Switzerland, but it may be in the label for the EMEA. We do not know yet. So it's a sort of a little arbitrary thing here in particular. Looking at the QUEST trial, which was addressing the efficacy and safety of cimeprevir plus PEC and riba versus PEC riba alone, you can see that if you had a genotype 1A and the presence of the Q80K mutation, note that that can be found in relatively high frequency in the North American patient population. It's somewhat lower in the European patient population, but you can see that the cure rates or SVR rates were only 58%, and that was only 6% better than PEC riba. So that tells you that the presence of this mutation has a significant impact, and obviously that's why it came into the label. Looking at the licensing naive trials for the grazeproof-elbasvir combination, so they looked at NS3-4A resistance-associated variants, so these are the ones which would confer resistance to grazeprevir. If you look at the genotype 1A patients, you can see that RAFs were present in 53% of patients, but SVR rates remained high regardless whether mutations were present or not. And what the Merck company always does is they look sort of at SVR rate in presence of NS3 RAFs with less than 5-fold potency loss to grazeprevir, and then they also look at a greater than 5-fold potency loss. If you look at the genotype 1B RAFs, much less present, so a lower probability of having baseline NS3 RAFs, but interestingly here, even if you have RAFs which have a more than 5-fold potency loss, you still have a 100% cure rate. So one of the important things to remember is that actually for genotype 1B, in many settings, other than for the decladisvir cimeprevir, we take that aside for a moment, resistance doesn't play a big role. So I think for your region, actually, it's going to be a very interesting question whether you're ever going to need any baseline resistance testing, because other than if you use the BMS compound, for 1B, the impact of baseline mutation is going to be less prominent. So probably from a public health point, you're going to use regimens which simply do not require resistance testing and are safe to use. And interestingly enough, that is also true here for the C-edge for the Merck combination. That's true for the NS3-4A region as well as for the NS5A mutations, where you do see no impact when you look at the RAFs, including those who have a more than 5-fold potency loss against elbasvir. You still have an SVR rate of 95%. But however, in the genotype 1A patients, and that's the basis of the label in the United States, which requires resistance testing, you can see that if you do have those particular mutations which are listed in the footnotes here, so the 30, the 31, the 93, then actually you do have only a cure rate of 38.5%. So in the setting of genotype 1A, that is the only genotype subtype where the presence of NS5A mutations have an impact for that particular drug combination. Now, it's fair enough to say that Merck started with their 15% cutoff, so they were more likely to find something. The Gilead company always used the 1% and did not show any impact in their overall analysis. However, one thing to understand is that it's very different than HIV. In HIV, if you have the 184V mutation, 3TC is not going to work, full stop. The problem is here that even if you have mutations, doesn't mean that necessarily the drug is not going to work at all. So that could be that the activity of the other drug takes care of that particular resistant variant. And usually you have to see it in the context of the difficult to treat patient population. So if RAFs come together with unfavorable host factors, which would be treatment failure, cirrhosis, unfavorable IL-28 genotype, that's when suddenly these RAFs seem to play a different role. And the interesting thing is that if you go to sofosbuvir lidiposphere and concentrate only on a sub-analysis in cirrhotic patients and look at those who have a more than 100-fold resistance by baseline RAFs to lidiposphere, then actually you see in the treatment experienced 67% only achieve SVR, which tells you that even in the soft lidiposphere population, you will have an impact if you have all risk factors together. And that makes it sort of complicated because it's not straightforward. So if you're naive, it doesn't matter at all. I think another point why probably resistance testing at baseline is not that important because you just have more favorable response factors enriched. However, in the setting of cirrhotic treatment experienced patients, actually these RAFs start to play a bigger role. Same holds true for simepivir sofosbuvir. So whereas, remember, the Q80K was mandated in the label in combination with PEC and RIBA, it was not mandated in the combination of another DAA therapy. So soft simepivir had better response rates when they were given together. However, if you look at patients who have cirrhosis from the Optimus II trial and have genotype 1A with the Q80K, you have the lowest overall response rate of only 74%, which tells you again, if all negative host factors come together, suddenly RAFs do play a role. So that's why I think in the context of more risk patients, I think we need to discuss whether there is a role for resistance testing or not. From the ABI3D regimen, the interesting thing here is to say that when you look at class RAFs, so NS5A variants altogether, and also look at those who have embidosphere, so that's their NS5A inhibitor in that mix, resistance-associated variants, you can see that the SVR rates have absolutely no difference in these genotype 1A patients, which tells you that the addition of ribavirin overcomes some of that reduced susceptibility. And you have seen in the previous presentation where our colleague has mentioned that if you actually have these RAFs and you want to treat with grazeproof albacvir, by extending treatment duration to 16 weeks and by adding ribavirin, you overcome the corresponding impact on SVR rate. And that seems to be the way forward here because resistance plays no role. So I think really the addition of ribavirin can be very important in that particular 1A risk patient. Can a resistance test guide treatment decision making in patients with prior failure of DAA-based therapy? So can we use resistance results to help us choose the next regimen? And I think there's very interesting data with that with regard to some of the trials we've seen. So patients who failed 8 weeks or 12 weeks of lidiposphere sofosbuvir were retreated in a salvage protocol with the same compound, lidiposphere sofosbuvir, for 24 weeks. And if you look at what impacted SVR, you can see that having cirrhosis, yes or no, at baseline did have no impact. If you had 8 weeks of therapy, you were more likely to respond than 12 weeks. And that has something to do with the fact, if you look at the baseline characteristics of these patients, that after 8 weeks of therapy, the presence of baseline RAFs was only 63%, whereas if you failed after 12 weeks, everyone had RAFs developed. So if you retreat and you had a longer duration or exposure to the DA, your likelihood of having significant mutations is going to be higher, right? And interestingly, they could show very nicely that depending on which mutation you had, you were more or less likely to achieve SVR. So if you had the W93H, then that was really your worst scenario, and only a third of patients responded. If you had the Q30R and the M28T, then actually everyone responded. Note, though, that combination of RAS was also unfavorable in that particular setting. Note also that at second virological failure, some of the patients actually then did develop sofosbuvir-related mutations. In the context of HIV and hepatitis C co-infection, there was a very interesting presentation at CROI this year. So in the IN4, remember that was the signature phase 3 trial for co-infected patients receiving 12 weeks of sofosbuvir. 9 patients developed virological failure. Remember that most of them were black, and there have been questions why that happened actually. And they were retreated with 24 weeks, so longer treatment duration at ribavirin. And I think we have to appreciate that this is something we would never do in HIV. You fail a regimen, you would never treat with the same regimen, it would never work, right? So that tells you that something is very different here in hepatitis C, because 8 out of 9 patients actually responded, right? Although many of them, or at least some of them, had mutations at baseline. So I think that tells you that the story is somewhat different. And obviously these are all patients with low risk because they were not cirrhotic, or very few of them were cirrhotic. I think there's still a lot to learn in that particular context. In order to learn, I think one of the most appreciated efforts in Europe, at least, are conducted by the group of Professor Sarrazin and Professor Zeutzem from Frankfurt, who really have, through great funding, been able to provide free resistance testing for anyone in Germany and many other countries who send in their sample. So basically, you send your sample to them, tell them what regimen the patient is on, and then they do the genotypic resistance test and provide you with the results. And so they have a subset of their resistance base, which now includes over 3,500 samples from persons who failed direct-acting antivirals outside of clinical trials, and looked at these various different combinations. You can see this is a predominantly a difficult-to-treat patient population. Very many have cirrhosis. A lot have failed a prior interferon therapy. It's a predominant genotype 1 population. And so the question is, if you use the guidelines and say, well, let's retreat with active DAAs, add ribavirin, and longer treatment duration, what kind of impact are we going to have? So they looked at patients who had either sofosbuvir decladisvir or sofosbuvir ledipasvir. So then you would expect those patients end up with an NS5A mutation, and indeed that's the dominant mutation they find. 77% have NS5A mutations, as you would expect. And then they said, well, sofosbuvir most likely has no mutation, so let's use that, plus a PI, plus minus ribavirin, so that could be soft simepivir, or use the AbbVie 3-drug regimen, where at least you have the option of the paracetapavir. I think you might worry a little bit about NS5A cross-resistance to abitavir in that context. And then they have so far only limited data, which they presented at EASL, but you can see that 6 out of 7 patients achieved cure with that kind of treatment approach. They looked at patients who had a genotype 1 and developed failure under simepivir, sofosbuvir, and you would expect there you would predominantly see the NS3 mutation. I would presume most of those patients have a Q80K mutation, and if they retreat those patients with Harvoni as a major approach, being a different drug class, well then obviously that was very successful in SVR12 in 20 out of 22 patients. And then they looked at patients who had failed on an AbbVie 3D treatment regimen, and that was retreated with soft-based regimens, and there was no data yet on outcomes, so we can't say very much about that. And then they had some data on genotype 3 patients who failed under soft ribavirin, who were then retreated with predominantly decladisvir sofosbuvir, and all patients achieved cure. So I think it gives us sort of a basis of, in the presence of the dominant mutations you find after failure, if you look for new drug classes or components which should remain active and combine them mostly with sofosbuvir, actually do achieve very good regimens. And I think that's a good message because it means that you can also salvage patients today with the regimens we have. Professor Ahn has shown you a lot of other combinations, sofosbuvir, grazeproof, elbasvir, or future combinations which you can use, but these are all not available at this time point. So in summary, ladies and gentlemen, after interferon-free treatment failure, hepatitis C variants resistance to protease inhibitors progressively disappear by population sequencing and are replaced by wild-type virus. In contrast, viruses' resistance to NS5A inhibitors and to NNIs persists for years, maybe forever, as dominant species already in place to prevent onward transmission and reinfection. In most patients who fail to achieve an SVR and interferon-free regimen, viruses that are resistant to one or more of the DAs administered are present as the dominant species at the time of relapse, so resistance is a real issue upon virological failure. By means of population sequencing, so you have to have a 15 to 20% cutoff, I think, because that is the only one which will appear to be clinically relevant. RAFs at baseline will have an impact on the rate of SVR with some of the interferon-free regimens, obviously particular for the 1A, as in the label for grazeproof elbasvir, obviously for the 1B patients who receive sanaprevir and decladisvir, but I think it's also true for patients who are cirrhotic, treatment experienced, and have all unfavorable host factors in the setting of sofosbuvir ledipasvir, so at least there is the question whether we might need resistance testing in that risk patient population. Extending treatment duration and adding ribavirin, though, seems the way to minimize the impact of these pre-existing RAFs on SVR. Thank you very much.